Hello.
السلام عليكم.
Alaikum assalam. Good afternoon, everyone.
Lynn, good afternoon.
1 second, I will arrange my microphone. Dr. Anagam, my voice is more clear now.
Yes, very clear.
Hello, everyone. Let's start.
Oh,
Today we have MSK session.
okay.
Uh, Before I start, I noticed that there are many confusion between our colleagues at the group about the sources we're studying and about how to deal with these short cases. My advice for all of you, uh, the exam of 2B is always bear some atypicality each time. Each time it is not like before. So in my opinion, practice as much as possible from big sites like Radiopedia, or if you are working in a big hospital, uh, don't confuse between the sources. I think most of them are similar. Even I face many cases in my practice typical to the Radiopedia cases. So don't confuse, don't waste time in searching in which type is the best, but practice. Why? The most important to build a strong clinical sense in the exam and under the stress condition. What is in your mind will appear, and this is the philosophy of the exam. They put both you, all of you, under stress and under a typical condition every time. Why? To discover what's in your mind, to explorate your experience. Okay, so dedicate your time to practice. I think, in my opinion, Radiopedia is more than enough. Since 1 year ago, Radiopedia has more than 30,000 full DICOM long case. I think no one can can finish even 3,000 case. So it is endless source. This is my advice for all of you. Um, we share. Dr. Naam, can you see my screen?
Yes, sir, I can.
This is not your case. Your case is this
Okay.
one. Okay. You know why?
Okay. Okay. So,
Because
yes.
always first case is not easy. This is my law.
Okay.
Yeah. Let's start our MSK Viva and oral radiology case session today. Candidate one. This is a 12-year-old male patient complaining of ankle pain after falling down. Go on.
Okay, so I'm presented with frontal radiograph of the ankle for a 12-year-old boy post-trauma. So I would like to have a general look and go systematically in this radiograph. I couldn't appreciate clear fracture line in either of the bones. The bone alignment is preserved. The cortices are intact. The ankle joint articulation is also preserved. Okay, so just however, there is reduced lateral space on the left side. This could be positional. The physes are intact. There is no suspicious bone lesion, no dislocation. So I would like to check the other views. Okay, so this is the lateral view. Again, the bone articulation at the uh, ankle joint is intact, no fractures. The dome of the talus is preserved. The calcaneum is also preserved. The Bohler angle is within normal.
What
The
else?
rest of the bones, yes, I think there is a discontinuity of the fifth metatarsal bone at the region of the
Don't
proximal
worry.
shaft.
Don't worry about it.
Okay.
At least in
Uh,
this lateral, you must tell important abnormality.
Okay, so yes, the Achilles tendon fat pad is slightly hyperdense.
Okay.
However, um, no avulsion fracture of the calcaneum or of any other bone, no OCD, I mean osteochondral defects.
No?
Oh,
What else?
the soft tissues
Yes.
are within normal. There is increased soft tissue opacity at the anterior aspect of the talus.
Okay. So,
Okay, so I'm concerned about eversion fracture at this site, given this age of immature bones.
mhm.
Uh, I I would like to check oblique view if available.
No
I
other
think yes.
views. No other views.
Okay.
Hmm.
Okay, so I would like to zoom at this point at the anterior talus to check for any small hidden bone fragment.
Okay, what is your next step?
Okay, so I will go for MRI.
Okay.
Okay, so this is the MRI. This is a steer, sagittal. There is joint effusion at the anterior aspect of the ankle. There is extensive pulmonary edema of the distal tibia and the talus. There is a bone fragment seen anterior to the talus. Yes, so I'm concerned about avulsion fracture. Rest of the bones are unremarkable with preserved articulation and no suspicious lesions. So my diagnosis is avulsion fracture of the talus. This is for urgent referral to the pediatric orthopedic team for further assessment and
Are you
management.
sure? Are you sure?
Okay, I would like to check the other planes, like okay, coronal or axial.
Which sequence?
Stair, it's good.
Coronal stair. This is axial. The only coronal is okay, fat set, no problem.
Okay, there is abnormal intensity
Stop me
seen
at
at the.
the slice of interest.
Okay, so just please here, please. One
Okay.
slide back. There is abnormal signal intensity seen at the distal tibia crossing the physis into the epiphysis. It is showing high signal intensity on this stair with surrounding low rim. So, given the position of this lesion and the signal intensity, I'm so much suspicious of Brod's abscess. My top differential, I would like to correlate this with the post contrast. Okay, so again demonstrated the extensive edema and the lesion tracking along the bone through the physis to the epiphysis. I would like to check for the presence of any sinus tract or sequestrum. I can see there is area of signal void over there in the middle, could be representing a bone fragment. So this is a osteomyelitis, Brod's abscess for urgent pediatric orthopedic referral for management, urgent management and follow-up.
Okay. What your explanation is for the complaint? The patient has trauma, and finally, your diagnosis was some infection, element of
Okay,
infection.
so foreign body that induces this osteomyelitis or
What
skin
else?
ulcer.
What else? Hello?
Okay, so
Yeah, what
yes.
else?
Okay, so I'm thinking in terms of trauma, introduction of foreign body, or uh, hematological spread from other site of the trauma.
Okay. So what's your final diagnosis, please, again?
It is broad abscess. This is infection.
What is the name of this sign?
Okay, the track is the cloaca, and the yes, and the hypointensity structure is the involucrum.
Okay, what is the name of the sign when there are very pathognomonic sign for Bruce abscess here? It is describe it and mention its name. What is this?
Okay,
What happened here?
it is there is a sinus tract along the bone to the subcutaneous tissue.
Okay,
This is
okay.
the
Describe well the sinus tract. Give me a more detailed description.
okay. So the tract is extending from the medulla of the metaphysis through the epiphysis into the physis into the
Yes.
subcutaneous tissue.
So what is the characteristic sign of Brody abscess here? Which one?
The cross of the physis.
Yes. So it is almost very unique to Brody's abscess. Okay. What is okay? There are another sign here.
The involucrum, which is sigmoid in the middle.
Um, what else? Hmm, what else?
Okay, the associated inflammatory signs of edema, effusion.
Okay. What is your management?
Okay, that is urgent referral to the pediatric orthopedic team for urgent commencement of IV antibiotics and
Mm-hmm.
follow-up. Culture sensitivity, maybe image-guided aspiration for culture sensitivity.
Okay. Okay. Thank you so much. The characteristic
Mm.
sign is this dark line. This dark
O-
line. It has very
Okay.
characteristic name. Penumbra
Uh,
sign.
o-
Okay.
okay.
It is different from penumbra sign in the perfusion of the brain. It's a totally different entity. But this is a penumbra sign. Plus, this is represent granulation tissue. Okay. Plus,
Okay.
crossing the physis is very, very characteristic of Brody abscess. Uh, this it was a Brody abscess case. What happened, my colleague? This is typical exam case. What happened? I gave her both ankle. I didn't tell her which site is a site of trauma. I gave her very vague history. Okay. And in the actual history, the patient has fever. Fever. If you look here, tenderness, patient, sorry, patient afebrile. Okay. Just tenderness and the swelling. This patient has all the trauma, and this is very important in pediatric. Children after trauma may develop infection. Take care, my colleague. So, when I was medical officer, I saw one orthopedic prescribe antibiotic post-trauma for 4 years child. I asked him why. He told me because he is very, very labile to develop bone infection after trauma. This is very common in children. So this is very important fruit of today's session. Number two, if you look here, very subtle lucency that not seen here. And look here, very, very subtle. Here, especially here, not seen here. So this very subtle. Take care, my colleague. In my two vivas, I presented with a bone case. that has some subtle finding like this. And I told all of you before, when you present it with X-ray of bone and it looks like normal, look to three parts. Number one, periosteal reaction. Okay. Number two, density discrepancy. Compare. Okay. If you didn't find anything, look at the soft tissues. And this is what happened here typically. What happened here? There are some opacity here. The retrocalcaneal pre-Achilles fat is not clear. And here, this is effusion, Dr. Anam. Okay?
Yes.
The
Okay.
ankle effusion, this is atypical. This is typical effusion. At least if you pick up any of these three findings, the examiner will let you to complete the case and will give you the what happened here. You put Dr. Nagam, sorry to judge you here, but this is for the benefit of all. You uh, prospectively judge in your mind, put in your mind, this is trauma and has effusion. So in the beginning, you told me, I see a valsed fragment, bone fragment here. And until the end, you insist this is a Walsham fraction of, I don't know which bone you mentioned. Despite I'm scrolling up and down, through and back, and there are here, see, cavity, cavity here, crossing the
Yes.
faces, causing defect associated with hyperdense fluid here. This is another entity. Okay. So don't precede the image and put a definite diagnosis in your mind. Expect expect one or two diagnoses, and when and see the image and another sequence. Sure, your diagnosis must change. Maybe change totally, maybe change for some complication, but don't insist in your diagnosis that you build from X-ray. Okay, all my colleagues?
Okay. Okay.
So,
Thank you so much.
welcome. So, it was a cavity containing a hyperdense fluid crossing physis, causing destruction here. So, it is aggressive, surrounded by marked edema. I must ask here, doctor, does the patient has any fever? You didn't ask about it, and it is very important. Okay?
Okay.
Okay, finally, it was Brody abscess. You did very well when you told me, doctor, it may be a sequestrum here. Okay, it was really very nice from you because it is very small. Finally, what is the management of Brody abscess, Dr. Ram, in your mind?
Okay.
In
It
your
is it
opinion,
is
sorry.
IV
Oh,
antibiotics.
antibiotics. Look here, what they are doing here.
Aspiration.
Creatage, aspiration. Okay, because it is abscess within the bone and something has been formed around it. Okay, something
Okay.
has been formed around it. Okay,
Okay.
so it may prevent, it is necrotic. This cavity means there are necrosis. So whatever antibiotic you give, it will not affect here because this is a collection of necrosis. It must be drained. So it was a Brody abscess. Again, look at the X-ray. Very subtle finding. Very subtle finding. Look, very subtle finding. To reassure you, almost you will be presented with one case like this. Don't be afraid. The exam, really, the exam
بسرعة
is markedly variable, and they must give you very typical cases, moderately difficult, and one subtle because you all of you has 6 cases only, so only one subtle case. Okay, my colleagues. Next candidate.
Okay.
Next candidate.
Hello, yes, I'm here. Hello.
Okay, 1 second. Hello, next candidate. This is, sorry, this is probably abscess. Okay. Doctor, this patient has 15-year-old female patient presented with knee pain and swelling after twisting. Please, my colleagues, mute yourself, except the candidate on the hot seat. Yeah,
Okay,
go on.
so I'm presented with MRI left knee. So at first this is a stair sequence. So I can see there was a sizable knee fusion with leveling. It's high T2 signal with leveling. Um, okay, and I can also see. Uh, okay, so I can see the leveling. It's clearly here, and then with the patella also I can see that um, the medial aspect of the lateral aspect, sorry, of no, it's the medial aspect of the patella. There is high signal within it, and also I can see which is bone marrow edema, and also I can see there is bone marrow edema at the lateral aspect of the tibial plateau. In my I want to look at the ligaments. So I can see there is abnormal signal within the insertion of the medial collateral patellar ligament. Um, uh, the lateral collateral ligaments is it looks fine. In my usual practice, I will also look at the other views. Like I can benefit also from the coronal just to have a look, and the sagittal to have a look at the meniscus as well as the ACL and the PCL. Um, and the coronal will also help me to look. Okay, so this is the coronal stair. I can see the ACL signal looks it's fine, and I also can see the PCL looks fine. Both menisci. Um, okay, both menisci. I can see abnormal signal within them. Um, okay, but in this I can also confirm there is a sizable knee fusion. Okay. So I will also just confirm in the sagittal just to further look at the
Which
uh,
sequence? Which sagittal do you want?
which segment. I'll look at the sagittal. Uh,
Yeah, yeah, I have T1, gradient, BD. Which one do you want?
I could look at
Only
the
one.
gradient just to make sure is this yes. So in the gradient, I can see there is. I can confirm there's a leveling. Um, uh,
Yeah, yeah, what
there
else?
is.
What does it mean, this leveling, doctor?
So the leveling it means that there is with the history of trauma. It means there is blood. Um, this is one of the things, and as it also could mean there is lipohemoarthrosis, but I will need to look at the T1 actually to if there is fat SAD, but in the fat SAD it was not. I think in the PD it was there was no any fat suppression, so this is mainly blood. Uh,
What's your
so
diagnosis, doctor?
this is lateral tibial translocation, giving the
Okay.
appearance. the tibia and also the edema at the lateral aspect of the tibia. So the next step, I will need to urgently inform the orthopedic surgeon for further management of this
Do
patient.
you have any signs of emergency here in this exam?
Signs of emergency.
Yeah,
There is
critical.
the bone marrow edema, and I was looking at the ligament, the medial patellar ligament. It looks to be the medial aspect have abnormal signal, so I'm thinking it could be actually torn at this aspect. So I think this is an emergency at this part. Yeah.
What else? Why does this dislocation happen?
Yeah, it usually happens because there's shallow intertrochlear groove, I think, between
Mhm.
them. I just forgot the name. Yeah, it's just the shallowness of the inter. I forget the name. I'm so sorry.
Okay. So
Yeah,
finally, what's your diagnosis?
it's lateral tibial translocation.
Okay, thank you, doctor, so much. Take some home message. What happened
Okay.
here? This is
Mhm.
lateral patellar subluxation or dislocation associated with what is this? Medial retinicular injury. And
Yeah.
the most important, what is this? What is this, doctor?
Bony
What is
fragment.
this?
It's a bony fragment. Mm.
Yeah,
Okay.
yeah, this is osteochondral fragment. This is emergency. Why?
Yes.
Moving loose body or fragment like this can block the joint.
Mm.
What is the source? This is the source here. Medial patellar facet. Look, medial patellar facet. Okay. Second,
Okay.
you should tell the examiner there are obvious of trochlear dysplasia.
Trochlear dysplasia. Yeah.
Trochlear dysplasia measure, you can't measure in the exam, but it is very clear. And this is the cause of lateral patellar subluxation or dislocation. Lateral patellar subluxation. Patellar, not tibial. See?
Oh.
Okay? Lateral patellar dislocation. Okay? Sometimes
Okay.
why we mention transient? Because it is dislocated and realigned again. The most
Okay.
important here is this fragment. Besides that, if you have a look here, you can notice that the patella is very high. This is patella alta, very important. Then my advice to you, don't judge about the ACL and BCL from the exam. In the exam, not very easy.
Okay.
Okay, ask for sagittal.
Okay.
So we have patellar
So usually I will
dysplasia,
ask for sagittal just to look at that.
sagittal, sure.
Okay.
Okay, so ask for sorry, there are trochlear dysplasia and
Trochlear
signs
dysplasia.
signs of patellar dislocation or subluxation and medial retinacular injury. This fluid level of effusion denoting lipohemoarthrosis. Okay, and I think lipohemoarthrosis. Okay, this fragment is the most important to be mentioned. Very important. If you wanted to give a grade to this osteochondral lesion, which grade do you want to give?
No, I don't know. I don't know.
Grade one, two, three, four.
It's far away from totally far away from its side. It's like a loose body. I think it's gonna be 4.
Yes, what is the difference?
I think it depends on the site first. So first of all, if just a signal, and then if it's just far away but
Yes,
still in the site, and then it's far away or dislocated far away.
yes, it is for why? Because it is totally dislocated from the donor side. Thank you, doctor, so much. The answer again here, my colleague. Take care, especially when the examiner giving you very typical case. يعني you should search for any emergency signs or any associated injury. Okay, my colleagues. Next candidate.
Assalamu alaikum, sir.
Salam. Doctor, this is 55-year-old male patient presented with foot pain.
Okay. I'm provided with the X-ray frontal projection of a skeletally mature patient who has presented with the foot pain. Uh, Firstly, I will look at all the bones. Uh, so I cannot see any significant joint space narrowing involving the metatarsophalangeal as well as the interphalangeal joints. There is uh, the tarsometatarsal joint also appears normal in alignment. There is no fracture or dislocation. I'm looking for any soft tissue swelling. So there is some suspicion of soft tissue swelling in the big toe. And also there is some area of lucency involving the distal phalanx of the great toe. So in my routine practice, I would like to review the other orthogonal view as well.
Where exactly, please? Which two?
So here, it's a big toe and the distal phalanx. There is some area of
Okay.
issues involving the distal phalanx with associated soft tissue swelling. Uh,
Okay.
so I would like to review the other orthogonal views to confirm this finding. There is no fracture and I cannot see any dislocation.
Okay.
Uh, okay, this is the lateral view. And I can see that there is swelling, definite swelling along the big toe, and I can see that there is uh, scalloping of the distal phalanx. Uh,
Hmm.
it could be due to an intramedullary lesion, or this could be outside the lesion, outside soft tissue lesion that is causing scalloping and contour deformity of the distal phalanx. So, can I have the oblique view, please?
What is your next step?
Sir, I will advise MRI. Definitely, I will advise MRI for further evaluation of this case. Okay, I'm provided with stirred coronal sequence of the same patient,
Mm-hmm.
in which I can see that there is a marked edema involving the distal phalanx, uh, and there is associated swelling and edematous changes are seen in the adjacent soft tissue as well. I can see that there is a focal area of hyperintensity with the inner hyperintensity involving the proximal phalanx as well. Uh, so, keeping in view these findings, Lisa, could you please scroll for me? Okay, I can see a few other areas of hyperintensity within the head of the metatarsal.
Don't worry about it.
In the,
What's your
okay.
diagnosis?
Uh, Sir, I cannot definitely make out a lesion in this case, and there is the diffuse edema and obliteration of the fat planes of the bones and adjacent soft tissues. So, along with skin thickening, so this could be an infective inflammatory process. Would be my first differential. This could be osteomyelitis. Now, if this
Mm-hmm.
patient has a history of fever, I would like to inquire about the history. Does this patient have a history of fever or raised inflammatory markers?
Yes, what else?
Sir, other than that, uh, sir, so can I have a T1 weighted sequence so that I can see the bone? I would like to see the bones on T1 weighted sequence. Okay. Uh, so uh, there is an abnormal signal intensity, hypointense area uh, that is involving the bone, and I cannot differentiate between the cortex and medulla on these images. Uh, there is loss of corticomedullary differentiation with abnormal signals within it. So, this could be, sir, do we have contrast sequences uh, to see if there is any abnormal enhancement? Yes. And uh, sir, I think there is some abnormal enhancement. Yes, I can see there is an abnormal enhancement within the residual visualized bone as well as in the soft tissue. Uh, so this could be uh, a soft tissue lesion involving the bone as well. Um, this could be, sir, uh,
Yes.
metastatic deposit. So this could be metastatic deposit if this patient has any history of known primary. Uh, so other than that, this could be, sir, a neurofibroma or like anything related to the nerve plexus. And so these are my possible differentials.
Finally, it is neurofibroma. Do you think this is a benign looking lesion?
Sir, this is sir malignant looking lesion. So since it is causing destruction of the bone and significant soft tissue swelling, sir, aggressive looking lesion. I mean aggressive looking lesion. So this could be, sir, an osteomyelitis or any, sir, neoplastic lesion involving the soft tissue. So I will advise biopsy. Definitely, I will advise soft tissue a biopsy of this lesion and then further management of this case.
This is bone scan of the same patient. What do you think?
Okay, sir, I can see. So this is the PET scan, and I can see that there is uh, multiple areas of uptake is seen within the lymph nodes involving the uh, inguinal as well as the femoral and in the lower limb as well. I can also see some. Uh, so, sir, this could be due to lymphoma. Uh,
Where is see where is the lesions that you are talking about? Request
it's a
control and show me, please. When the examiner asks you, show me or
yes,
indicate with the mouse
yes, yes.
for
So
me,
can you see my?
don't panic. Don't panic. He wanted to be sure that you are in the right pathway. Show me where is exactly the lesions
Uh,
that
so,
you are describing.
sir, I'm describing about these lesions. So these well circumscribed uptake
The
skin.
mouse the mouse didn't move with you.
Uh,
Move the
so can you
mouse.
see? Yes, I'm moving the mouse. Can you see?
No, no, the mouse is not movable.
So I have requested the control.
I approved. Again, request again. In the through exam, you are not in need to make any request or anything. They arranged and fixed the setting, and you just will go scroll, use the mouse. Everything is very ready. You can show me where.
So here I can see that there is uptake within the lymph nodes. So these are likely
You mean this? This?
yes, so these focal areas. Yes, sir.
This?
So here I can also, yes, sir, this one here, sir.
Do you mean any, one second, do you mean any other lesions?
Uh, so I can see that there are multifocal areas of uptake
Where?
within. So here
Where?
I'm pointing above the bladder, sir, above the
See
bladder
your
and
mouse,
below.
your mouse didn't move. Okay, above the bladder here. Any
Yes,
other
sir. Yes, sir.
lesions?
Yes, sir. So below in the soft tissue of the thigh as well, and sir in the leg as well. Yes, sir.
This and
These are.
this? This?
Yes, sir. Yes, sir.
Okay, so what's your final diagnosis?
So, sir, on looking at these images, I'm thinking about, so this could be granulomatous disease like sarcoidosis that is causing enlargement of the lymph nodes. Other than that, this could be a lymphoma uh, that shows
Do you
increased
think,
uptake.
doctor, one second. Do you think any of the diseases that you just mentioned will cause this type of destruction here, or this type of infiltrative mass-like lesion? See, look at T1.
Yes, sir.
Do you think nearly the phalanx is totally infiltrated?
Yes, sir.
Okay. And what happened here? What is
So there
this?
is skin ulceration, a skin ulceration,
Yes.
sir.
So
Uh,
your final diagnosis, please.
Sir, this could be again, sir. I will say inflammatory and infective on the top, osteomyelitis, sir. Other than that, this could be sir malignant process like
Yes.
uh,
Thank you so much. Your next step, you mentioned to biopsy. Okay. Thank you so much. The answer, my colleague, this is melanoma, grade 2 melanoma. At least she mentioned that this is aggressive. Why? Because there are erosion here. Okay. See, my colleagues, if anyone presented with food, most of us will concentrate it. Is this less frank? There are any base fifths, metatarsal? Is there are any gout? But the lesion here. Okay. This case was about satisfaction of research or satisfaction of search. See, erosion here. Okay, then she asked for MRI, and the MRI was so helpful. There are soft tissue mass. Soft tissue mass. I think a granulomatous disease will not enhance like this. This is a true mass enhancement, distracting or erosing the bone. Okay, so at least uh, finish your statement with this is aggressive lesion. What happened in this? This is a PET CT, and this is multiple other melanomas. Okay, this is not lymph nodes. This may be lymph nodes, but why? Because these are large and very near or abutting the skin. So this is another lymphomas. Sorry, another melanomas. Look here. You will see all of them. Look, see. We didn't see before a subcutaneous lymph node like this. Okay, all of them abutting or infiltrating the skin. Look, so it was a case of melanoma, multifocal, and the examiner just give you the beginning of the case in the distal first phalanx. Thank you, doctor, so much. Next
thank you, sir.
candidate.
Assalamu alaikum.
Salam. Doctor, this patient has knee pain and stiffness, 20 years old.
20 years of old.
What do you think?
So okay. So I'm provided with the MRI, T1 weighted, T2 weighted images, corner section. I can appreciate, I am looking all the images first and then I will convey my findings. There is no definite fracture or dislocation noted. So can I scroll? I have requested.
Okay, but please don't move to the answer. You can use the arrow, please,
Okay.
or this sidebar.
Okay. So you can scroll. I cannot be able to scroll sorry. Please, you can scroll. So in these images, I am looking for any fracture or any dislocation, which I cannot appreciate. Now I am looking at the meniscal sides.
Are you
Okay,
think?
but
Do you think? Do you think menisci are assessed in T1 and Cronin?
no.
See,
No, I
see.
am
The-
yes.
see. You like this, you give the examiner impression that you are not usually doing MRI. Okay?
Okay.
Okay. Which sequence do you want?
Sagittal image and
Sagittal
PD
and
V2.
sagittal BD. Sagittal like this,
Yes,
okay?
sagittal PD.
Hmm.
So I cannot appreciate any bone marrow edema. ACL and PCL are intact. I'm looking at the patella, which is unremarkable. Patellar tendon and quadriceps tendon appears unremarkable. There is okay, this is the lateral meniscus, interior and the posterior horn, which is normal. Lateral meniscus is larger as compared to the normal interior horn. I want to look the medial meniscus. Medial meniscus is also normal. There is no evidence of any subchondral or osteochondral defect seen so far. There is no FEN noted in a young patient. Okay. There is no, okay. So can I see coronal fat set?
Leave the mouse, please. See? This is the crown.
On the coronal images, I'm looking for the soft tissue areas. There is a subtle abnormal marrow signal along the lateral aspect of femoral condyle,
Yes.
which is subtle. Yes. Yes, I can appreciate that hyperintense signal is noted along the lateral femoral condyle. But there is no abnormal signal noted along the lateral collateral ligament. These lateral femoral condyle abnormal signal could be related to some injury or some subchondral defect.
Mhm.
I will look for it. So please scroll the images. No, I cannot appreciate any subchondral defect. Can I see, sir, axial
This is the axial.
fat set? So this is the axial fat set images. Previously, I can also appreciate some high signal within the medial aspect of the patella. So please scroll the images. No, I think so. It is projectional. No, if one is noted.
What's your diagnosis?
So far, I can only appreciate high signal along the lateral femoral condyle, which could be related to some previous injury along the lateral collateral ligament.
Mhm.
Without any evidence of any fracture fragment.
Yes, what's your final diagnosis?
Sir, it could be a tendinopathy of the lateral femoral condyle.
Okay. Doctor, look here. What is this?
So this is the high signal. Yes, this is the high
This is
signal
not
in the.
projectional. 1 second.
Yes.
You saw it here. All of this projectional. Very,
No.
very difficult to be projectional. So what's your diagnosis?
So it is the abnormal marrow signal interior to the tibia and posterior to the patella. It could be bursitis. And Hoffa fat pad bursitis is a
Oh,
differential
okay. What is
diagnosis.
the name of this disease? When the Hoffa bad in a specific part of it get high signal like this.
So I don't remember the name exactly, but yes, there is a name of this bursitis.
Okay. If you has this, by the way, this is not purely precise. If you have the same high signal, but here, what's your
Okay.
diagnosis? What is the name of the disease?
Yes, it could be along the quadriceps tendon and upper pole of the patella. It is So one is the oscillator and
Okay, another question. If you have, this is another structure. If you have deep to this structure, here
letter,
some
yes,
fluid or some inflammatory fluid. What is the name of this syndrome?
iliotibial tract on
Yes,
the
yes,
band syndrome.
excellent. Friction syndrome, friction, F-R-I, friction syndrome. Okay, thank you, doctor. What happened here? There are edema here, where in the soprolateral part, here, here we are in the lateral. Why? This is the fibula, okay? And this is not the shape of medial tibial plateau. So we are in the lateral. There are edema, marked edema at the soprolateral part of the Hoffa bed of fat. Okay?
Yes,
Okay? Why?
yes,
Because
sir.
of the maltracking of this patellar, patellar tendon. So it is a syndrome. What is the name of this syndrome? This is impingement syndrome. And this is Hoffa bed of fat. So it is Hoffa bed of fat impingement
Impeachment.
syndrome. Okay? When the same
Okay, sir.
finding presented here superiorly, we call it soprolateral impingement syndrome. When the same finding presented here deep to this iliotibial tract, we called it iliotibial tract friction, FRI
Friction.
syndrome.
Okay.
Okay? Three
Okay, sir.
different
Thank you.
impingement syndrome. But here, if you could note, there are some element of patella alta. And if you look here, there are also chondromalacia patellae. But in practice, really, the knee should be at least flexed 30 degrees to judge well about the patella alta, either it is true or projectional. So because this knee is not in the proper position, I can't comment on the patella alta. Okay? Look here again.
Okay, sir.
Also, you feel there are some subluxation, lateral subluxation. Why? Because of this one. Okay? What is this? I think this is patella alta because the patella is very high here in axial. In addition, also there are trochlear dysplasia. Okay?
Okay, sir.
Also, if you look here, this is abnormal signal of the lateral aspect, lateral facet of the patella. The cartilage is totally bright. This is abnormal. And if you look under it, there are some marrow changes. So this is chondromalacia, at least type 3 or 4, because I can't detect well if there are any defect here or not. But at least tell the examiner all this finding. Okay, my colleagues. Then you will see the other finding from ACL, BCL, menisci, all of this. In my opinion, my colleagues, you should have a rapid look about menisci and the ACL, BCL. Okay? Either you will find something very obvious or not. If you didn't find something else, search in the other syndromes that my cases of today is demonstrating, are demonstrating it. Okay?
Okay, sir.
Next
Thank you, sir.
candidate. Next candidate.
Yes, yes, sir.
30-year-old male patient presented with thigh pain after running.
I'm presented with the axial MRI. Can I scroll? Can scroll,
Yes,
sir?
request control. Request.
Okay. 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 I'm presented with the axial MRI T1 of the both thigh of an adult male presented with thigh pain after running. I will scroll from top to bottom before start commenting. I can see the muscle. I from first look I couldn't get a major abnormality. However, I can see there is a slightly hyperintense signal on the left thigh medial compartment, slightly more than the right side. I'm not sure. Okay, I will bone signal look up normal. There is bilateral knee joint effusion. Both patella look in normal position. Muscle, rest of the muscles they look normal also, and bone marrow, no abnormal bone marrow signal. Both femoral heads are normal located, also no abnormal signal. Both I cannot get a major abnormality in a patient who's running. I'm searching for any muscle tear or abnormal fluid collection or stress fracture.
What is your next step?
Uh, I will check other sequence. I will try check a coronal CAT images.
Leave the mouse. Leave.
Okay.
Go on.
Okay. Okay. This is presented with coronal stir images. The same patient, I can see there is abnormal high signal in both medial compartments of both thigh in the adductor groups. I think this could be due to stress. This sport chronic avulsion, chronic
1 second.
stress
Leave the
injury to
mouse.
this.
Leave the mouse.
Okay.
My colleague, please mute. Go on, doctor.
Okay.
1 second.
Um,
1 second. Use the mouse. On. Go on.
okay. I can see abnormal high stir sequence, almost bilateral symmetrical in both medial compartments in the adductor groups. I need there is also abnormal signal in the both site of attachment of ischial tuberosity. I think this chronic stress uh, injury due to sports in correlation to the patient clinical data. So I will convey the finding to this referring physician, and I will advise for modification of this ex exercise pattern, and recommend some non-steroidal analgesic for the pain, and follow up if needed.
Yes.
I don't see any
So,
abnormal localized fluid collection to suggest any tear. So I think it's just a stress injury. Could I
what
don't
is
think
the
it could
name
be.
of this? What is the name of this stress style muscle injury?
Mm, no, I'm not sure.
Okay. Look here.
Okay.
It is affected. Yes, the adductor muscle.
Yes.
Which adductor? What is the name of this muscle?
Um, this one. I
Which
forgot the
adductor?
name.
The most superficial one. Which adductor? The most anterior.
No,
Hmm.
no,
The most anterior.
semimbrons are posterior.
No. No.
No.
You are talking about the hamstring. The most
Yeah.
anterior adductor one is adductor
Magnus,
longus.
longus. Oh.
Yes, the most adductor one, anterior one. The most posterior one is adductor. You think is this one? Magnus. In
Longus
between,
magnus, yes,
in
previous.
between the third one, adductor previous. Okay, so this is you mentioned this is again because I wanted to tell the true answer. A stress type of muscle injury or disease. Okay, it has a specific name. Look here, delayed muscle soreness. Look here. Use the mouse.
Okay.
Delayed onset muscle soreness. It is a fatigue type of micro trauma to the muscle. Okay, fatigue type. It is bilateral, nearly symmetrical, and very common in athletics runner like this. Okay. It may persist for months after long running or the type of trauma. It must be follow up to rule out any partial injury or whatever other injuries in the future. This type of muscle soreness is treated conservatively, need rest, vitamins, and whatever. Okay, my colleagues, bilateral
Okay.
symmetrical muscle edema like this, called again delayed onset muscle soreness. Why delayed? Because it happens after a time after the long running or the type of trauma. Thank you, doctor, so much. Last case, this patient, last candidate.
Hello,
A
sir. Candidate 6.
30-year-old male patient presented with shoulder pain. Go on.
Okay. This is X-ray left humerus of an adult patient. I am first looking at the bone. The acromioclavicular joint appear normal. The humerus appear normal. The obvious abnormality is there is a lobulated increased density area is seen along the medial aspect of the distal arm. It producing focal skin bulge. No underlying calcification or differential density is seen. I cannot appreciate any abnormality in the underlying bone. So I would also like to evaluate this on the other orthogonal images. And this is likely a soft tissue mass in the distal arm. And I would like to see the other orthogonal views and would evaluate this further on the MRI.
What's your finding, please?
Sir, a lobulated, a soft tissue density mass along the lateral aspect of the distal arm, along the medial
Okay.
aspect of the distal arm.
Medial, not lateral. Okay.
Yes, medial. Okay.
Why
So
this?
this is
Why they didn't proceed to MRI? Why?
because uh, because maybe they because of the age of the patient, or maybe they suspected some collection or
No, because this is soft tissue, so ultrasound is the next step. maybe lipoma,
Okay,
fibroma, something will
okay,
be diagnosed accurately through the ultrasound. Okay,
okay. All right.
this is the
Yeah.
ultrasound. What's your opinion?
Okay, on the ultrasound image, I can appreciate that there is a heterogeneous area is seen involving the subcutaneous tissues of along the medial side of the elbow. It shows a few internal cystic areas and a few hyperdense, a few hyperechoic areas, which is showing posterior acoustic shadowing. And I would also like to review the Doppler images to comment on the internal flow. Um,
What's your
yeah,
diagnosis,
this area
please?
shows, yeah, this shows a marked internal flow. So it's likely it's likely an aggressive, it's likely a mass lesion. Um, so it's like an aggressive mass lesion, and I would like to evaluate this further on the MRI as it is showing internal flow.
What do you think?
Okay. Okay, these are MRI T2 weighted images. Okay, I can appreciate that this is a there is a well-defined T2 hyperintense lesion is seen involving the medial aspect. It is it is in it is seen involving the intramuscular compartment, um, and it is abutting the adjacent vessels. So I would also like to review the T1 and the post-contrast images as well, to look for any post-contrast enhancement.
Post contrast.
Okay.
We don't have post contrast. What's your
Post
final diagnosis?
Sir, it could be if patient has any prior history of trauma, this could be any hematoma formation, um, or I would if yeah it or any uh, it looks well defined on the MRI and with internal heterogeneity. Uh, it, um, it is it is not appearing hyperintense on T1, so it's not a fatty lesion.
Yes. See,
Other
tell me about the location again.
uh,
Where is the location? You told me it
sir,
is
it's
abutting the
intramuscular.
vessels. No, not intramuscular.
Yes.
Not intramuscular.
Okay. Okay.
Okay. You told me
Okay.
it is abutting the vessel. What does it mean for you? Lesion
Uh,
abutting the vessels.
yeah.
And if you
Sir,
look here,
it's is it yeah, it looks yeah,
yeah,
sir, it looks heterogeneous in T2 and it's also spindle shaped
yes,
it's likely a schwannoma, a nerve sheath a schwannoma
yes,
which appears heterogeneous on T2.
yes. Thank you, doctor, so much.
Yeah.
Hmm. Yeah, what is your next step?
Yeah, so I would convey my findings to referring physician. This patient needs a orthopedic referral for and discussion orthopedic MDT. Um,
Orthopedic? Are you
for
sure? Are you sure?
soft tissue.
Orthopedic, yeah, didn't have any relation to the soft tissue.
No.
Okay.
So okay.
Surgeon, general
Neurology.
surgeon, yeah. Okay, neurosurgeon. Okay, thank you, doctor, so much. What
Okay.
happened here, my colleague? Shoulder X-ray. See, and if you miss this one, and you told the examiner the shoulder, whatever you will tell have lucency here, or whatever have some abnormality here, he will ask you what will you do, and If you ask for MRI, whatever you will ask, then he will close the case. At least in the best scenario, he will ask you, please concentrate in soft tissue. If you didn't look down in the periphery of the film and pick up this one, you will lose the case. Very important. Next step, always think in ultrasound before MRI or CT, especially in simple soft tissue mass like this. Then the MRI show a mass. This is not intramuscle. See, the muscle is separated. It is just compressing the muscle. It is follow. Look at this nerve. This follow and inseparable from the neurovascular bundle. This is the neurovascular bundle. Go down. It is centered and abutting the nerve. Heterogeneous, heterogeneous lesion with cystic changes, many features of schwannoma. Or sorry, if you if you mention this is a nerve sheath tumor, whatever it will be, malignant, schwannoma, all of this for pathology, at least you reach most of the correct answer. Finally, after biopsy, it was diagnosed as malignant peripheral nerve sheath tumor. So the term of peripheral nerve sheath tumor is more inclusive. It includes everything, either it is malignant, either it is schwannoma, fibroma, whatever. Okay? So finally, see, these diagnoses in Radiopedia are written after pathology. This is a PET CT. Will show, by the way, I think, many other lesions. Look here. It needs time to download. So it is a case of film periphery. Take care, my colleague. Today, I think all the 6 cases, each one has a trick. I think 2 or 3 were about the film periphery. Thank you, my colleagues. Thank you, our coordinator. Let's meet in another new session. Goodbye.